So welcome everyone to the session today, beginning the afternoon session in Parkinson's disease. My name is Daniel Kremens. I'll be chairing with Dr. Isaacson. And the debate today, we're going to have Peter Jenner. Professor Peter Jenner is a specialist in preclinical aspects of neurodegenerative diseases, notably Parkinson's disease. He has spent the major part of his career at King's College London, where he was head of pharmacology for 14 years before returning to his research roots and subsequently becoming emeritus professor of pharmacology. Peter has experience in drug metabolism and pharmacokinetics, but neuropharmacology based on functional models of neurodegenerative diseases has formed the major focus of his work. And he will be debating with Dr. Rajesh Pahwa. Dr. Rajesh Pahwa is a diplomat of the American Board of Psychiatry and Neurology and serves as the Laverne and Joyce Ryder Professor of Neurology, Chief of the Parkinson's and Movement Disorders Division, and Director of the Parkinson's Foundation Krupp Family Center of Excellence at the University of Kansas. Our debate today will be, despite the increasing levodopa and adjunct dopaminergic therapies, off-time persist. This may indicate the limitations of presynaptic dopaminergic pathways to fully resolve off episodes. Striatal adenosine receptors are overactive in PD and impact direct and/or indirect pathway activity. Should non-dopaminergic receptor antagonists be added to levodopa as soon as fluctuations emerge? Dr. Jenner.
We had music, but we...
Oh, yes, we have our vote. Yes, so let's bring our vote. Non-dopaminergic mechanisms should routinely be added to levodopa when off fluctuations occur. All right, oh, well, it's still moving a little bit. So I think there we are. So 59% say yes, 41%, moving only 40. Just give me a minute, as I'm saying. We'll say it's roughly 60-40. Peter, why don't you take us away?
Thanks very much. It's great to be here. I'm sort of here to support change. Do you ever feel things in Parkinson's disease don't change as quickly as you would like? Do you think we just keep doing the same old things again and again? I'm sort of in favor of looking at Parkinson's disease through new eyes and trying to find other strategies that will improve the quality of life of patients with Parkinson's disease. So that's sort of the approach I'm going to be taking today. I've got to show you my disclosures. I may mention drugs for which, from companies for which I have received honoraria, but the bottom bit's the important bit. What I'm going to say to you is what I think and what I believe, and it may not reflect anybody else's views whatsoever, so I take full responsibility for it. And what I'm going to do initially is I'm just going to dissect the capsule. I just want to look at the premises we're working on. Are off periods related to presynaptic dopaminergic function? Does dopaminergic function fully reverse off periods? Do off periods have a non-dopaminergic component? And if they do, what are we going to do about that to change the way that we approach this topic? And I want to start here. I just want to start with this, just to get a little bit of common ground and agreement with you. I think everybody here would agree that off periods affect almost every patient with Parkinson's disease. I think you'd accept that off periods have both motor and non-motor components. I hope that most of you would agree that off periods occur much earlier in the course of the disease than we used to think. and that even today that we currently think they do turn up very early in the illness. And the last bit is that I'm sure you agree, because this is the way most people approach the disease, that the idea is that if you give more continuous dopaminergic therapy, if you have continuous drug delivery, then what you're going to do is you're going to deal effectively with off periods. So let's, oh, wrong button, there we go. So where does that idea come from? Well, it comes from here, something which has endured for more than 25 years. And it's this idea that in the early stages of the disease, levodopa and dopamine is stored in remaining presynaptic dopaminergic terminals, and it buffers the brain against changes in plasma levodopa levels. But as the disease progresses and the terminals degenerate, you lose that storage of levodopa and dopamine, and what you start to see is a shorter and shorter duration of effect of each dose of the drug. So this idea that everything to do with off periods is presynaptic is something which is ingrained into the way we treat Parkinson's disease. But to be quite frank, this simply can't be true. It just isn't true. Simply because you also get off periods when you treat people with dopamine agonist drugs. Now, dopamine agonist drugs don't have a presynaptic component to their action. These are drugs which interact with postsynaptic dopamine receptors. So there has to be a postsynaptic component to off periods. And if you then retreat to the preclinical world, if you go and you look at the 6-hydroxydopamine lesion rat, if you look at the MPTP-treated primate, before you start administering drugs in these models, you've got 99% loss of presynaptic terminals. So there's very little room for any presynaptic component. And when you do treat repeatedly with L-DOPA, you see wearing off in these experimental models of the disorder. So there clearly is something going on other than presynaptic. Postsynaptic would be the guess, and probably something beyond the postsynaptic receptor. And the reason I say that is that if you look at postsynaptic receptors in post-mortem studies, if you look at them in experimental model studies, then there is absolutely no consistent evidence at all that there's any desensitization or tolerance at the level of the postsynaptic receptor. If it's not at the level of the postsynaptic receptor, it has to be further down the chain. And once you're further down the chain, you're clearly in non-dopaminergic territory. So at this point, let's turn the whole thing round. So the mantra goes, if you give drugs more continuously, dopaminergic drugs more continuously, if you use a continuous drug delivery strategy, then that's the way to approach off periods. And certainly there is significant benefit when you use that type of strategy. But if you do a sort of meta-analysis and you start looking at the advanced therapy studies which were published at the time of this paper, and you start going through the treatments one by one, then you see if you use the reticotine patch, you can reduce off time by 32%, so you've got 68% remaining off time. Apomorphine subcutaneous infusion, you can get a 60% improvement in off time, but there's still 40% which is not responding. If you go down to levodopa intraduodenal infusion, you get a 60% reduction in off time. So again, there's 40% that's not responding. And you have to remember this is in optimized rates of infusion drug delivery. This is often with additional oral levodopa treatment. There is this component to off that does not respond even to the most sophisticated delivery systems for dopaminergic drugs. And, you know, just to be inclusive, if you go to Lecagon, if you go to levodopa, carbidopa, entacapone, intraduodenal delivery, it's the same story. If you go to phos-levodopa, phos-carbidopa for subcutaneous infusion, it's the same story. So there is something in there which does not respond to dopaminergic treatment. And if you put up a great big spreadsheet like this, if you go through every parameter you can think of, you compare these treatments, transdermal patch, subcutaneous delivery, intraduodenal delivery, if you go through this, The only commonality that you can find is that there is a non-dopaminergic component within the cause of those off periods that you're trying to treat with dopaminergic medications. Now, I'll throw in a few caveats to keep, hopefully, some people happy. It's certainly true that you may get a complete abolition of off periods using an advanced therapy in some patients, but that's certainly not true of everybody. It's certainly true that in some patients, upping the dose of dopaminergic therapy may be limited by the onset of adverse events. But that's not true for everybody either. But there's a thing in here which is fascinating and we need to understand. When you say you're treating off periods using these therapies, what are you treating? Are you treating predictable off periods, such as wearing off, that the patient was suffering from? Or are you treating unpredictable off periods that most patients were also suffering from? Or are you treating both? And my guess would be that the dopaminergic components in here are the predictable off periods, and that's what you're reversing when you do this. And it's the unpredictable off periods which will turn out to have the non-dopaminergic component. So, where are we? Dopaminergic approaches, of course, they're very useful. You can significantly reduce off periods. But you do this at the risk of increasing classical dopaminergic adverse events. And while you use dopaminergic medications as the mainstay of treating off periods, there is still a significant component which is not responsive to dopaminergic treatment. And so what you have to do is think a little bit outside the box. You have to think about, well, what are we going to do if we don't use a dopaminergic approach? And obviously, you've got to be sensible about this. You can only use approved medications depending where you live, depending on your regulatory authority, depending on availability of the drugs. There's really only two non-dopaminergic approaches which are currently available for treating off periods. First of all, you have delayed release, extended release amantadine, which is approved, and this is a benefit of amantadine for both the treatment of levodopa-induced dyskinesia and off episodes. And then in US and Japan, you have the use of the adenosine antagonist, istradefylline, again, as an adjunctive therapy to levodopa. So there are two approved non-dopaminergic approaches to the treatment of off periods. And you couldn't actually have two more different drugs in many respects. Amantadine, you might think by now we would have sorted out pharmacologically because it's been around for 40 or 50 years. But actually the mechanism of action of amantadine is far from clear. It certainly acts through NMDA-mediated glutamate receptor antagonism, but it also has actions on dopaminergic pathways and a number of other receptor systems. Now, the multiple mechanism may be the secret of amantadine's action and efficacy, but of course it can also lead to tolerability problems and problems with off-target actions. And those of you who use amantadine will know that common adverse reactions to the drug include hallucinations, dizziness, constipation, peripheral edema, orthostatic hypertension, falls, etc. Istradefylline is a completely different kettle of fish. It's got a single, very focused mechanism of action. It only acts on adenosine A2A receptors, which themselves have a very selective localization to the indirect output pathway from the striatum, the no-go pathway, as it's known. The drug has no other pharmacological effects, and because of this focused mechanism of action, what you have is an adverse event profile which is very different from that of amantadine, and where dyskinesia is the major problem that you're likely to encounter. And that mechanism of action is very interesting indeed, because what you find is that the indirect pathway, which we all know to be involved in motor changes in Parkinson's disease, is overactive during the course of the illness. And adenosine itself acts on these A2A receptors to put further tone into that pathway and increase the effect of the no-go pathway in reducing motor function. And what istradefylline does is it blocks the effects of adenosine on the A2A receptors. It allows a reversal of the activity of the indirect pathway towards normal, and what it does is it allows dopaminergic function to be fully expressed as a result of that activity. So it releases the brake, allowing motor function to be more fully expressed. So the final question is, when should you do this? Why wait to treat with a non-dopaminergic therapy? And what I've done on the left-hand side of the slide is I put back up what I showed you about what we could agree about off periods at the very beginning. I think we can agree that they occur early in the course of the disease, and often really much earlier than most people think. The problems associated with treatment are the same in early disease as in late disease, with no evidence that the mechanisms underlying off periods changes over the course of the disease. And the problem we have at the moment is continually increasing the overall dopaminergic load in patients with off periods leads inevitably to an increase in the number of adverse events that are experienced. And so what you have is opportunity. You have opportunity early in the disease to add in a non-dopaminergic approach to treating those off periods. And if you do that, I think you might easily find that what you're doing is producing a levodopa or dopaminergic load sparing effect. And I think at the moment we're underusing non-dopaminergic approaches to treating off periods, and I would encourage you to try this in your practice. And I think if we do that, then maybe we can have some change in the way that we approach the treatment of the disease in general, and maybe you'll get increased benefit and increased quality of life for your patient population. And with that, thank you very much indeed.
Well, Dr. Pahwa, Dr. Jenner has raised some interesting points for you to counteract.
Or you can choose not to.
Thank you. Dr. Jenner gave an excellent presentation, trying to tell us that, yes, dopaminergic therapy does not completely eliminate off. There is still off there, but I did not see any data from him actually showing any improvement in off, but he argued very well that there are other options to treat off. The other thing is, when we talk off, he kind of mentioned the severity, but he didn't go into it. So even though the off may still be present, maybe it's not as severe. So those were a couple of issues that he kind of didn't mention. So this is, as you know, and I'm going to argue against no, we don't need additional therapies. So what do we have today when a patient does have motor fluctuations? We do have different kinds of levodopa available. Then we have different adjunctive therapies. I'm not going to talk about amantadine ER because on his slide, he did talk about dopaminergic mechanisms in it too. So trying to talk about a drug that may be non-dopaminergic but does have dopaminergic effects, it could fall in either. So let's focus on the A2A antagonist, which I believe is a truly non-dopaminergic activity that it has. And to me, if we look at this slide again, you have different forms of levodopa, and then you have infusions of levodopa. Do we really need other adjunctive therapies? But that's a discussion for a different day. Today, let's just focus on A2A antagonism. So we all agree levodopa is the most effective treatment for Parkinson's disease. It is the gold standard for the treatment of Parkinson's disease, and multiple studies have shown that it improves the motor functions related to Parkinson's disease. And here I have two different forms of levodopa, immediate release and extended release in early disease, showing a good improvement in the motor symptoms. Not only we know that it improves the motor symptoms, but it also improves the other symptoms, activities of daily living, quality of life, global impression that the patient has, both from the patient standpoint and the physician standpoint. So all these we have shown do significantly improve as far as Parkinson's disease is concerned. Not only that, in patients who do develop motor fluctuations, who develop off time, using extended release levodopa preparations, and here I'm showing you two different kinds of extended release preparations, IPX066 and IPX203, which are the two long-acting available in the United States. And in the first study, I'm showing you reduction in off time, and the other one is improvement in on time without troublesome dyskinesias. And this study that one of the speakers in the morning also brought up is when you convert patients on immediate release and put them on sustained release, there's an improvement seen both in off time and good on time. And then when you randomly put them back on the drug, the patients who are on extended release still stay better. So it's not an issue of levodopa, it's basically how do we use it, and we can reduce off time using the drug. Not only with oral preparations, but what about infusion therapies? And here I do have carbidopa, levodopa, enteral suspension, and carbidopa, levodopa. And again, with both these preparations, you see an improvement in off time, as well as reduction in off time and improvement in good on time that is seen. And again, this is a significant improvement that is seen. Now, if we look at their adjunctive therapies, these patients, in addition, like you see, are taking 77% on dopamine agonists, 40% on COMT inhibitors, 18% on MAO-B inhibitors, and in spite of that, there was a reduction in off time. And in the subcutaneous infusion, 71% of the patients were taking other Parkinson's medications, and we do still see an improvement in off time that happened with both these preparations. The other thing is often people talk about, oh, levodopa, it works great initially, now we have reached a point, so we need non-dopaminergic therapy is what we indeed need, and that's where we need to see the improvement. However, we have shown that levodopa is effective throughout the disease course. And here you have 0 to 5 years, 5 to 10 years, 11 to 15 years, and greater than 16 years. And you do see an improvement in activities of daily living, as well as motor scores throughout the disease course. So the issue is you will see an improvement no matter how long the patient has Parkinson's disease, and this significant improvement is seen in all the cardinal features: tremor, bradykinesia, rigidity, etc. The other thing is when you compare levodopa with other adjunctive therapies, you see that levodopa does have better improvement. And here I'm showing you a study comparing carbidopa, levodopa plus entacapone versus extended release carbidopa, levodopa. And again, in spite of that, extended release carbidopa, levodopa had better improvement in symptoms than patients who were also on adjunctive therapy. So let's talk about A2A antagonism. And as Dr. Jenner explained the mechanism, it's a very interesting mechanism. Basically, as you saw, as dopamine is lost, A2A have an increasing braking on the normal motor control. So I'm not going to repeat what was just said earlier. And to show you in a different form, green being, so to speak, the direct pathway, being levodopa, and red being the indirect pathway. So for the lack of better term, we'll call it braking. But remember, the role of dopamine is to give you gas, give you gasoline, speed it up. What we are saying is, well, adenosine, if we give them a A2A antagonism, we're going to release the brake. I don't know about you guys, but if you're driving a car, you need to give it gas. Just releasing your foot off the brake is not going to make the car go. So that's the one thing you have to remember, is that without gas, there's really not much you can do taking the brake away. The other thing is, like I said, we did not see too many data coming out from the A2A study, and actually there are 8 studies out there looking at both 20 milligrams and 40 milligrams. And if you look at the reduction in off time compared to placebo with 20 milligrams, it's about 0.38 to 0.75 hours a minute, hours a day. So again, you're looking at a modest improvement now compared to the infusion where you're looking at close to 2 hours, looking at other preparations in respect to IR over an hour. So really, you're seeing very modest improvement that are seen adding an A2A antagonist. And if you look at it, what is the minimally clinically important change? We have shown in study that the minimally clinical important change is at least 1 hour. So the A2A did not make it, and in fact, the European authorities did not approve the drug in Europe because of the concerns as far as reduction in off time and improvement is good on time is concerned. The other thing is side effects. Again, if you look at the side effects, and I put dyskinesia as the main one, really you still see dyskinesia as close to 20%. So you're still having dyskinesias with very modest improvement that you're seeing with A2A antagonists. Now let's put all these adjunctive therapies together. So you have reduction in off time with 20 milligrams, and if you take 8 studies and pool them, it's a reduction of 0.38 hours a day. You take the 20 milligrams and just put the 4 positive studies, it's 0.75 hours. 40 milligrams, the 8 studies is 0.45 hours, and with the 40 milligrams, 0.82 hours. So none of the data actually reached 1 hour. As compared to, if you look at the IPX 066, even the immediate release carbidopa, levodopa, carbidopa, enteral suspension, IPX 203, or false carbidopa, levodopa, all of them did meet the target of minimally effective dose improvement that is 1 hour. So when I look at it, yes, maybe they play a role in it, but I don't see really good data to recommend adding a medication to reduce off time where we have a very effective levodopa preparation available in different forms where not only can I improve the off, but I can also improve the severity of the off. Thank you. Peter, your rebuttal.
Dr. General, rebuttal?
You get a rebuttal, yeah? No. Keep it short.
He didn't tell you how he was going to solve the bit that doesn't respond to dopaminergic therapy. There were still 3 hours of off time in most of the studies that were shown. Also, the changes with istradefylline are over and above what could be achieved with maxed out dopaminergic therapy. So they're not instead of dopaminergic, they're over and above. The clinical trials are clinical trials, they're not the real world. In the real world, we know that istradefylline works better with low threshold doses of levodopa. And even in animal experiments, it doesn't work well when you give it with maximal doses of levodopa or other dopaminergic therapies. So I would say that don't always believe what you see in the clinical trial. We need them for registration purposes. Real world experience of these drugs is far better than the artificial world of the clinical trial.
Dr. Pahwa? No rebuttal? But we have some time then for questions. Would anyone like to approach the microphone and ask a question?
The question I have, so we talk about adenosine and glutamate receptors, and these are the postsynaptic medium spiny neurons. And there's lots of other receptors that are being investigated, GPR6, new ones. Do we have to restore the normal chemical features and activation of the postsynaptic system in order to get more continuous stimulation overall? Is this part of CDS?
Right. From a pharmacological perspective, even from a physiological perspective, I'm not sure we really understand what causes off periods. Okay?
Clearly Pahwa doesn't. Clearly Pahwa doesn't.
What I think the message I'm trying to give is you're not going to get rid of those off periods by just adopting a dopaminergic approach. If you've got other tools in the toolbox which are non-dopaminergic, in individual patients, give those drugs a chance, because what you might be achieving is maybe only 1 extra hour a day on top of the dopaminergic therapy. But in my world, 1 extra hour a day is a benefit for that patient, and I'm sure they would view that in terms of their quality of life.
Peter?
Yeah, another non-dopaminergic therapy, which is often overlooked for increasing on time, if you look at those studies that looked at Hauser diary data from both pallidal and subthalamic nucleus stimulation, is the effect of DBS. And I think it's the Deutschel overview of a couple of studies. I think the improved on time in diary data in blinded paradigms was about 2.3 hours. And these are people, of course, heavily medicated with dopaminergic therapy, be it levodopa or agonist. The nice thing about that work, of course, is it clearly specifies the site of action. It's not in the dopamine receptor, and it's something that patients gain in addition to all the other benefits of DBS.
Yeah, so one, they actually do better than 2.3 hours. Most of them is 4.3 hours. So it's better than any medical therapy. Because I want to mention it because my next talk is going to talk about it.
I think the 2.3 is just if you subtract out the sham treatment.
No, even with the sham treatment, it's 4.3, even subtracting the sham.
You got to talk.
Okay.
I just want to mention, Dr. Jenner mentioned that it was done on top of dopamine. In case of other dopaminergic levodopa formulation, both oral and non, not only was done on top, it was done on top of optimized IR with less frequent dosing. So why not give the best base levodopa, be it subcutaneous or oral, and then if needed on top of that, but not adding it to IR where all the studies of all these drugs are.
That was for you, Peter.
You'd see, I would still argue, studies are studies. They're fine. They're fine. You need to do these to market your drugs and get approval from the FDA and the European authorities. I would argue, even though I was connected with the istradefylline studies for 25 years, I would argue that they used the wrong protocol for those studies, because all the science shows that adenosine antagonists work much better with low sub-threshold doses of levodopa, and you can use them as a levodopa-sparing strategy if you employ them much earlier in the disease than they're currently placed. And I know you've got to live by the approval, the label, and the guidelines, but sometimes a little bit of lateral thinking, I think, would be a wonderful thing in Parkinson's disease pharmacotherapy.
So Peter is saying, believe me, a low dose, forget the data. The data is not important, and it was actually the company that messed up after doing 8 different studies.
We have time for one more question.
Yeah, for both speakers, how about the non-pharmaceutical medication, for example, TMS or electrical stimulation or other exercise can treat the off? What are your comments? Yeah.
So actually, if that would be outside this discussion, we would have to have a different discussion on that. But again, if you start talking DBS versus dopaminergic therapy, which actually is the final debate of the day, I may have a different view when I discuss that because I'm discussing the other angle. But the point you're making, yes, there would be. But in this discussion, in this debate, we were talking more against an A2A antagonism. And that's the data I said we don't have. Same thing when you talk exercise. We don't have any data showing exercise actually reduces off time in a controlled study. There is data that people who do exercise is better than they don't do, but again, we have not looked at it as far as reduction or in fluctuations is concerned.
I would simply add, this is not about, it's just istradefylline. This is about non-dopaminergic approaches to treatment. And the way you would like to go about it is a non-dopaminergic treatment. This is horses for courses. This is not a single disease. This is something where you're going to get different effects of different therapies in different people. More tools in the toolbox, the better you are able to control your patients.
All right, so can we bring up the vote, please? Let's see what's happened. So let's go ahead and do our post-vote. All right, I think the yes has it. Great debate. So now we're going on to
The next debate. All righty, so we're going to make Professor Pahwa work here. Talk a lot about motor fluctuations and patients' perceptions and recognition, difference between tremor and dyskinesia, and how can we do better. We have diaries, we use video diaries, and emerging are wearables, and wearables combined with artificial intelligence may be a way to help our patients recognize motor fluctuations and dyskinesia, and may be a way to optimize our clinical care. In the next debate, we'll have Professor Pahwa arguing, yes, that optimal Parkinson's clinical care should always include wearables that incorporate artificial intelligence. Contrary will be little Richard Dewey III, who will be arguing no, wearables plus AI are not always needed. So you want to bring up the voting slide? Let's see what we all think before. So should optimal Parkinson's disease clinical care always include wearables plus artificial intelligence to interpret the wearables? Looks like, Professor Pahwa, you have your work cut out for you. Pahwa, you have your work cut out for you. Dewey, you have nowhere to go but down.
All right. So we are going to talk a little bit about variables and clinical care. And these are my disclosures. So basically, I'm going to discuss that we can improve better recognition as well as better treatment of patients if we were to use variables plus artificial intelligence. So let's first talk about variables. What are variables and why is it so important? And pretty much I would say majority of the patients in this room are wearing some sort of variable to actually on their body, and that data is being collected whether you know it or you don't know it. So that's already being collected, including health data. So what it does is provides continuous, objective, real-time monitoring of symptoms. And these can be smart watches, it can be sensor-based trackers, it can be ring-based trackers, so there are different forms of trackers that are available. And this tracking can be active or passive. So when we talk about active is that we are wearing it and we actually do some tasks, let's say finger tapping or holding the hand out, so we have to actually do something, as opposed to passive, which we are just wearing and we are not doing anything and the data is being collected. One of the challenges behind wearables is that there are multiple platforms available and also multiple devices available. So that kind of makes it a little bit challenging, because if I were to stand here and say, oh, so-and-so works great, someone else may say, well, I tried a different variable and it didn't work. The other thing is a lot of people don't realize on the variable too, on what they are seeing an improvement. You know, someone may talk about, oh, the bradykinesia scores didn't improve, but if you're looking at fluctuations, those scores may not be as important as seeing a reduction in off time. So the other thing is also there are different softwares available. So not only do you have devices, and to me, the ideal wearable would be that the person is wearing all the time, such as an Apple Watch, or even if they're not wearing it, something like an Apple Watch, which looks pretty nice. It's updated regularly. So all you have to do is update the software. And again, on the software, then we come down to a fewer number of different variables rather than having 25 different variables that are being looked at here. So what are the key applications in it? Well, one, recognizing bradykinesia, recognizing tremors, recognizing dyskinesias, recognizing fluctuations during the day. The other thing is actually monitoring medication response and when the patient is actually taking these things. And the other thing is that the goal of this is not just monitoring symptoms, but also the goal being that how can we improve patient care? How can we reduce the patient visits? How can we keep those things doing better? And also trying to track the sleep, the autonomic symptoms, and very near in the future, right now you can do blood pressure monitoring, but wouldn't surprise me in a few years we would be able to do it with routine monitoring or routine watches that we are doing. Now, on top of this, let's talk about artificial intelligence. And artificial intelligence has become kind of confusing because people think, oh my God, artificial intelligence, they're going to take my job away or something of that sort, or they're someday going to take the society over and we're going to have artificial intelligence leaders. But really it is to help us make our life easier. For example, I wanted to go to a famous restaurant here. There was no bookings available. So I decided I'll write a nice letter to the restaurant chef asking if I could join it. I'm coming from US. I'm just here on 2 days. But again, I don't speak Czech, so how am I going to write a letter? So I basically asked the GPT to write me a letter to the chef. I'm visiting from America, and it pretty much sent a nice letter for me saying that I'm here and I would like a reservation. I would really appreciate it. And I got a response with the reservation. So again, this is something that really artificial intelligence made this possible, because otherwise I wouldn't know how to write a letter. I wouldn't know how to write basically in Czech asking for these things. And that's what we have to do to make science, medicine, wearables easier, not replacing us, but helping us. And in future, I didn't do that, but you could basically ask artificial intelligence to make me slides for so-and-so talk, and it may have done that for me better than Dewey Jr. would do kind of a thing. So the other thing is the variable data is very sensitive and very specific. So again, when we talk about patients, it depends on patient recall, what do they remember, how bad their day was. Here you have actually an aggregate of the days that they have seen. And the other thing is variable takes a whole bunch of data and actually breaks it down for the clinician, that it makes the visit more efficient for them. Because initially when we were talking about variables, it's like, oh my God, I don't have time to look at 30 days of data. But what artificial intelligence does on top of it gives me the important data that I actually need to kind of make it easier for me. So basically it's improving patient engagement because they are like looking at it, they are taking part of it, they feel like they're taking part in their care and all that. It helps with clinical augmentation for the patient. The patient is much more taking their medications on schedule. That improves their outcomes in addition. So these are important things that we see improving the patient using with it. We do know, and we saw in the previous talk too, that there's a lot under recognition of off period. So when we try to, I don't know what happened with my slide on the other side, but when we try to actually have patients look at off time, it's really a difficult challenge. And when we add questionnaires, they can actually improve if the patient is having off time or not. And on top of it, now that if you add a variable, we can actually make that a much easier way to recognize these off periods. What about dyskinesias? Dyskinesia is one of the major challenges patients face. both as far as trying to separate tremor and dyskinesias, as well as how bad they are, what time they are present. So again, a wearable will give us a 24-hour tracking on whether the patient has dyskinesias. With traditional assessment, we are really looking at during the clinic visit. And often patients, before they come to the clinic, take an extra dose of levodopa because they want to be in their full-on state, which may result in more dyskinesias. It kind of takes away the observer bias that is seen. So some patients may not even recognize they have dyskinesias. Here we have a variable giving us a much more idea on how the dyskinesias is during the day. And same thing, it's also very sensitive to help us and reduces the patient burden. The patient does not have to remember it, keep track of it. We don't have patient diaries that are used in clinical trials, etc. So this is another very objective way that we can do it. These have been validated in multiple studies, and this was in a study of over 500 patients where it had a much higher level of tremor detection in Parkinson's patients versus controls, and this highly correlated with the motor UPDRS scores. So not only was a wearable able to actually look at and recognize tremor, but it was able to differentiate it from a control group of patients. Similarly, if you look at comparison between tremor and dyskinesias, it did a very good job of a sensitivity of 0.97 for tremor and 0.62 for dyskinesias. Now, dyskinesias can be a little bit challenging, especially in the hands and in the actual region. But I think over time, as the algorithms improve, this will be much more sensitive too, because a lot of these movements can be, at times, be mistaken for other movements before we actually fine-tune some of these algorithms that are present. So wearables plus AI is our goal. We are not talking just purely variables here. We recognize variable by itself can be a challenge, but adding AI is the specific outcome that we really think would be important, because doing that not only helps the patient or the caregiver for that side, but also makes the clinical outcomes for Parkinson's much more important. If you look at medications, the patient is much more likely to start taking their medications on schedule. And whether we look at off time or whatever, taking medications on schedule will give the patient less off time and more on time. So that's an important fact to remember. It'll help. It'll keep track of how active the patient is. Someone earlier asked about exercise. Well, we don't really know how well they exercise, but basically, this would tell them, okay, you had a very slow day yesterday, you need to speed up, no one needs to call them. AI is checking at it and trying to figure out why the patient didn't do it and remind the patient from that. You start a new therapy, it can help the titration on saying, okay, today you took X number of pills, tomorrow you need to do something else, and warn patients when they're at a fall risk, as well as recovery from falls would be other things that AI would improve. Recently, we had a big issue with the nurses saying that they don't want AI to replace them. And like I said earlier, AI is not replacing anyone. It is supposed to help make life easier for the medical provider. But if you're looking at an error rate comparing an actual human nurse versus an AI software, and as here you look at providing medical advice, the AI is superior to the nurse. Causing no harm, again, AI is less likely to cause harm from that. And whether you look at minor harm, severe harm, or even death, it has a much, much lower risk of these things. The other thing is also reducing the cost as well as visits. So if you look at as far as visits to the specialists are concerned, we have shown it reduces it by about 18%. And if you look at visits to the ER, it reduces it by about 43%. So wearables or AI can also reduce those visits. You can improve the compliance to over 75%. So that's another major improvement that you'd see. So cost reduction and care optimization is what we are going to look in the future. And we have been doing the traditional way for years. And now we need to add wearables plus AI to actually improve this for our patients. What also we know if the patient takes medications on schedule, we have seen that they do indeed have improvement in their symptoms. And here is showing you 4 examples of a patient. And basically, this is since they got into the program on how much their tremor improved over time. And that's basically the patient taking their medications on schedule, their refills occurring more on time, and basically based on the software coaching the patient and improving them. So again, variables plus AI is really an important thing. We think it optimizes management, reduces visits to the expert, reduces ER visits. It improves patient engagement. It improves clinical capacity augmentation. And finally, it actually is much more valuable than providing traditional care by itself. Thank you.
Dr. Dewey?
All right, everybody. Well, to start the lecture, your guys' gut instinct to vote no on this is the right gut instinct, and I'm going to talk you into why you are right to begin with. These are my disclosures here. And we have a long prompt here. Should wearables be used routinely in patients or only when history or examination is unclear? I'm going to argue no, 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 no for all of it, and perhaps we'll then make the case from the greater to the lesser about maybe there being a case for this when really the clinical situation is unclear. But I think that there's compelling reasons why this is maybe not the panacea that we have been hoping for. First of all, I just want to admit that this is a little tricky. This is a list of studies showing that to be ignorant of the problem might be better for patients. I've even numbered it for you. There are no studies. This is a little bit off the script. But I wanted to go through the kind of philosophical challenge of how might granular detail like this really hinder holistic approaches to patient care. And I want to hang my hat in arguments on a couple of these points you see above me. One thing I didn't specifically call out in this PowerPoint is that question of AI and how AI is going to magically reduce our work-life balance construct and how it's going to improve patient outcomes. The major limitation with AI is that it is going to evaluate the data that it is given. And what they say is trash in, trash out. And so I'm going to argue just from the standpoint of our limitations with wearable devices that this is not necessarily going to work out like we hope. But as you can see up above here, tracking Parkinson's symptoms over a day, I'm going to make the case, is going to take more than a wearable. Device adherence to actually wearing the wearable is an issue. I got to ask the question, will this tracked data actually result in clinical changes that we make at a clinic visit? And then patients, of course, could have anonymity concerns regarding the continual tracking of what might be personal data to them. And I just want to reference what I have called here death by tweak. And that is where we continue to adjust medications in response to complaints, problems, issues that may or may not be medication related, and it turns into a whirlwind and a cyclone of perhaps patient mismanagement. And I'm going to give a couple examples of that later. I show this slide again simply to highlight once again that off and wearing off and motor fluctuations is a whole constellation of symptoms. And when we're talking about what a wearable or sensor can really provide by way of analysis for these things, we're limited. It's not going to tell us a lot about weakness necessarily unless it has a task where we stop our day and pick up dumbbells. It's not going to really give a good assessment of sweat unless this has special sweat detecting glands and autonomic system plug in. We don't have this kind of technology yet. Pain, aching, again, this whole host of non-motor symptoms that can play in the overall fluctuation landscape, it's just not going to be touched upon with this kind of technology. I look at it this way, and I like analogies. As I was putting this together, I thought of essentially what we're talking about with wearable technology is sending a movement disorder specialist to the home of a patient 24/7, However, that movement disorder specialist has their ears chopped off, can't use their eyes or ask the patient any questions, and has to purely by feel identify everything that is going on with a patient's abnormal movements. And you can see there that there's some inherent limitations and perhaps error that is going to be introduced into that analysis. The other issue, and Dr. Pahwa did touch on this already, there are a lot of different devices, not one single gold standard, and the bottom line is that we're not even using wearables. This is as general neurologists and movement disorder specialists. Again, as I talked about earlier this morning, on a Likert scale, they are marking whether they are sometimes, never is not depicted here, or maybe almost always or always using any of these modalities to really assess for fluctuations. And of course, you can see here, lower down at the very bottom, using wearable technology is not popular to date. Let's go through some reasons why. When we're talking about gyroscope or accelerometer-based analyses of a patient's symptoms, I think we got to talk about what is it actually measuring. When I get data spat out from these things about an off state, a patient doesn't seem to be moving as well, they are bradykinetic. Well, what is it really measuring? Is it just measuring a paucity of movement? Are we talking about when it tells me that there's dyskinesia, are we reading on movements that are of a hyperkinetic nature? There's a lot of overlap in the movement disorders world, and there's a lot of movements that we'll see in the clinic that demand and necessitate follow-up questions to really delineate what exactly is going on. We can have patients where in the off state, they are uncomfortable, almost an akathetic state as described back in the 80s, or a restless legs symptom overlay that's beginning as their dopamine state is beginning to be depleted, and they start to actually move around more, walk around more. Are they developing dyskinesia? No, they are in an off state. But we could wind up seeing wearable data that points us in the exact opposite direction of what we're trying to do. You can also have a tremendous number of patients with non-tremor predominant Parkinson's disease. And you can't really rely on a readout of simple oscillatory rhythmic movement around a joint. And so what are we looking for? Are we looking at gait speed? Well, what if they have festination? What if they are in a near dead sprint just to try and recover their balance? And this is occurring at times, of course, when their medications aren't working as well. And again, I think an overall assessment of lack of movement can be confusing. Maybe they're taking a nap. Maybe they're sitting and watching TV. There's a lot to this picture that is just simply not being assessed by a wearable as we have in our modern technology age. I do allow that we could get cameras in everybody's home and have a big, giant Orwellian eye staring at a patient 24/7. But we just don't have that technology yet. I don't think that's going to gain great acceptance for obvious reasons. And so we have to play to what the limitations are as we see them. There's a whole host of other symptoms that you're not going to be able to strap a wearable onto. Their jaw to assess for jaw tremor, an internal tremor that people may feel. So again, limitations here. Also, we should mention patient adherence. As I do have a little bit of experience with these devices, I can tell you that we don't need to worry much about AI reading back months and months of data. The patient won't wear them for months and months. They already have smart devices. They're wearing a smartwatch with Siri on it that can tell them about when it's time to take medications, or their phone can give them alarms on which to take their medications on time. What we're going to find is that these devices have to strike an extremely delicate balance between not being too invasive and then also not having enough features. And it's a balance that I'm not sure any device really can fit. Remember, it's going to be constantly reminding them about their pills. That's great, but there's a certain kind of patient that has an active lifestyle and doesn't like the continual interruptions of that medication alarm going off. They will ditch this thing very quickly. Alert fatigue can set in. And of course, if the wearable is asking for particular motor movements to make an assessment during the day, patients quickly tire of that. And then there's people that won't remember to charge the battery at night. This is a whole nother device in the smart device ecosystem that we're seeing now a trend of just overall, I think, apathy towards as the populations grow older and as people are getting more and more fed up with it. There also can be issues with not enough features, and again, if there isn't a medication reminder, well, then we can't really tether any of this wearable data to whether or not their medications were taken, whether they are in an on or an off state. And without frequent adjustments being made by their physician based on the data we're getting here, they're probably not going to see what's worth. And then how often are we as providers really ready to stay on our toes and adjust the medications based on the data it's giving us? I ask you, will it matter? And off time, remember, can be a product of much more than just pill timing. Can be a failed dose due to GI motility issues, food or medication interactions. A patient may be exercising at a certain time of day and more rapidly depleting their dopamine state because of it. And I just don't see how wearables can track every single item of a patient's day and gather it into a meaningful way to help make changes with this. And I do think wearables are just going to shine an uncomfortable spotlight on how erratic our pills can be. Again, are patients just going to get frustrated and want to start a pump because of these? And are we at risk of over-medicating or under-medicating? I'll just briefly make the point about anonymity here that patients may not like this. They like a private life. They like to be able to come into the doctor's office and not be chastised over their missed medication doses. Believe it or not, when we're talking about pills 4, 5, 6 times a day, adherence rates are known to plummet. And it's very unlikely your patients are taking their pills correctly every single day. Are they going to get uncomfortable with this being on display each and every time they come to the doctor's office? They may not buy into this. So I want to just briefly go into a couple of hypothetical scenarios. And these are dreamed up, but I don't think these are too, selective or hand-picked. These are fairly realistic instances where I think we could see wearable technology working against us. Let's take Jack, for instance. He's 60. He's maybe 2 years into the diagnosis of Parkinson's disease. He's struggling with motor symptoms later in the day. And perhaps because of lack of time, perhaps because the symptoms are a little amorphous, we transition to a wearable technology to try and gather some more information about overall motor status over the course of the day. As we know, 2 years into the disease, we could be seeing true overt motor fluctuations. He comes back in for a recheck quickly, and what the data is showing you from the wearables every day at 2 to 4 p.m., he begins to develop more tremor and bradykinesia. That's what the wearable is telling you. It looks like an off state. He's been on immediate release carbidopa, levodopa 3 times daily up until this point. And so based on these findings, you start to bring the patient into a closer together, maybe more frequent dosing pattern of immediate release carbidopa, levodopa. That may or may not be the preferred step to take based on our other talks today. However, the wearable continues to tell you that nothing's changed, nothing's happening. There continues to be off time at 2 to 4 p.m. And actually now the wearable is talking about some sporadic dyskinesia occurring in the afternoon as well, still with a paucity of movement also, and it's just these brief sporadic bursts. It becomes very confusing. And Jack gets frustrated, no wonder. So does his physician. The physician's wondering why their patient with early Parkinson's disease is not responding to immediate release carbidopa, levodopa changes and is bringing up perhaps atypical Parkinsonism, although dyskinesia would argue against that. They're starting to talk about perhaps amantadine. It's turning quickly into a nightmare. And then perhaps 4 months later, Jack is diagnosed with a medical comorbidity, severe lumbosacral stenosis and arthritis to the spine. And of course, that would be in a pattern of discomfort and basically impairment later on towards the end of the day where a patient wouldn't want to move as much, would not be getting up spontaneously to walk around or move around, and may even be slower in their movements because of pain to the back. With therapy and conservative measures, the back discomfort is alleviated. Jack's monitored activity levels in the afternoon begin to improve, and you've subjected him to quite a bit more therapeutic intervention than was perhaps needed. Then you also have Sarah, who's 73 years old, gets excited about wearable monitors and wants to try, gets a touch anxious about having to wait 6 months for provider appointments, and looks at this as an opportunity to help with that. Essentially, to make a long story short, I can see here where data begins to pick up on off time. that she hadn't even really initially noticed herself. Perhaps some trace amounts of tremor begin to emerge as she's moving into the 30-minute time period prior to another dose. And medication adjustments begin at the next appointment. She's ready for another dose realignment for further tweaking and residual off. And this quickly begins a chase for an ideal, perfect, all in the green zone motor state that may or may not have anything to do with the patient's true subjective experience or desires for quality of life. My last point here briefly before I close is that this technology wants to and is marketed as a way to bring motor assessment to the world. This is to fill that gap so that you don't need to see a movement disorder specialist. You can just see a general neurologist or even a primary care doctor who's expected to take this data and make therapeutic decisions. I worry that this won't necessarily lead to better outcomes. I don't know that the wearables will be easy to use, and I worry that AI won't be able to decipher a patient's goals or day-to-day needs. Thank you.
Rebuttal, Professor Pahwa?
So first of all, he's saying, I don't believe this will, and I showed you data that patients had improvement in tremor once they went on wearables, they had reduction in ER visits, they had reduction in visits to the experts. Secondly, he's worried that the movement disorder specialists would be kicked out, and these are the fear mongers out there. Oh, the nurses are going to lose their jobs. Oh, the neurologists are going to do their job. No, it's going to make our life easier. Now, he's showing us examples of extreme, and I didn't go into examples. I could tell about a patient, and this is all AI. The patient wakes up in the morning and is having difficulty walking. The bot AI tells the patient is something wrong, and it replies back saying, oh, I just don't feel steady, I'm feeling unsteady. Oh, did you take your blood pressure medicines to raise your blood pressure? Oh, no, I've not had any water or anything. So patient is a little dehydrated. He's not doing well. The patient drinks more water, the blood pressure gets better, the patient gets better. There has not been any communication with the physician. That's what we are talking about artificial intelligence, that the patient reports a symptom, the bot replies back, and if it needs, it can tell, no, you need to contact your physician. Saying that the patient was having gait difficulties, well, the bot would have asked, what's wrong with you? Oh, I have back pain. Oh, you're having back pain? Why don't you talk to your physician? No physician is going to just go ahead and increase it depending on the variable. That's why we need to have AI to help us answer some of these questions rather than talking about just wearing variables. Talking about shuffling gait and all, well, it's not just the number of steps. It's the speed. It is taking how big the steps are. All that is being recorded. Same thing, the algorithms are differentiating between bradykinesia, between tremor, between bradykinesia, tremor, dyskinesias. So there are algorithms that are already doing that, and if anything, these are going to get better. AI is going to get better. Our life is going to get better. So really, we are not talking purely variables. We are talking variables plus artificial intelligence, which is what we will have in the future. Thank you.
Dr. Dewey, any rebuttal?
I would just say it's easier here to argue from the standpoint of a critical pessimist, but you are hearing of a little bit of tension in this, of the future, the optimism, futurology in a sense, and then I think real life. Yes, the bots can come to our aid and pepper the patients with 100 questions all throughout the day. Will the patient engage with that? Will realistically us as a profession really be able to lean on that kind of technology for real clinical answers here? I think that obviously the question of how to clinically manage motor fluctuations and an entire patient's good motor control during the day is going to be a more nuanced, more complicated issue that wearables are not going to be able to provide as much help for as we'd like.
It's not will, we are there. We have data to show that patients are engaging, quality of life is improving, so it's not may or if, it's already there. Thank you.
Questions? Discussion? I'll give you one. Raj, so do you think that these wearables, the next generations and future generations, will be linked into DBS parameters be linked into continuous subcutaneous infusion parameters that will allow in real time the sensing of stride length becoming shorter, swaying and balance and posture, and then increasing the stimulation, increasing the infusion rate to compensate in a real time, much like diabetics might do with a closed system.
Yes, I think those things will happen. We are in certain ways already looking at the DBS that was approved in US last week, actually last month, sorry, which is going to be a closed loop that's going to look at patients' wavelengths and actually change the parameters. Again, those are controlled, so you don't have to have it. The patient's parameters can automatically, you can still give them a little bit of how high the parameters can change. Same thing with infusions. Yes, we could definitely have such a system where during days or during the time the patient is not doing well, rather than a patient pushing an extra dose, is going to actually recognize that and maybe an hour earlier make those changes. So I think it may not happen in my lifetime, but it'll definitely happen.
And time for one quick question.
So how come neither of you mentioned research? When are we going to get rid of Hauser diary, since Bob is not here, where it's a switch instead of a dimmer switch, and introduce wearables which will truly be a dimmer switch and show that a lot of those drugs actually make people on throughout the day. We just don't detect it on a binary Hauser diary. How about that?
That's a great question. You know, Stan, if you would fund a study like that, which I hope you are doing, we can actually show that using variables during the day. And I think, you know, Bob is a good friend of mine, but I think we are past using diaries. We should have gone into these variables at least a year ago. But I think that's what the future is going to be. No one is going to be sitting and filling diaries. We are going to be basically wearing variables to see reduction in off time and dyskinesias.
All right, so can we bring up the vote?
Good job, man.
All right, so it looks like the noes have prevailed. The Luddites win.
Hey, it's improving.
You're going to do this introduction.
Yep.
Stand for a minute. I'll be right back.
Very good. All right, you guys, we're going to be going into the next topic here. This is an exciting topic for me. Our kind of bow and ribbon around the topic is that dopamine agonist therapy in Parkinson's disease should avoid predominant D2 family receptor affinity. And this is a controversial topic. As growing up in a neurology family and seeing my father put a lot of patients in the exciting 90s and 2000s on dopamine agonist therapy, and then watching him in the last couple of years now take them back off, it's been an interesting time to really kind of see how D2 non-sparing dopamine agonists really play into our modern therapeutic landscape. And of course, I think that we are going to have some excellent clarity brought to the issue by Dr. Jenner and Dr. Isaacson as they argue both points. What we'll do is perhaps start with a little pre-voting. Have a couple votes coming in.
Ooh.
All right. Well, so we have, yes, that we should avoid predominant D2 family receptor affinity. And I know that our speakers are going to touch on it, but of course, we are having a changing landscape of where we have a D1 selective dopamine agonist being evaluated and coming to market soon. D2 receptors and a high binding affinity for it does seem to drive certain side effects in the Parkinson's disease world, previously underreported back early in the 90s and early 2000s, but now coming into focus. So I will let Dr. Jenner here take it away.
Thanks very much. I don't think I have to. I think he said it all already. So if you don't vote for me, nobody will. I can tell you. And my argument will be, do we just have to keep doing what we've always done? I rest on your example of your father changing his practice and moving into it and moving out of it again. Anyway, you will have gathered by now, if you heard earlier, I'm a heretic, and I'm quite expecting to be taken outside and hung and burnt at the stake when I've finished doing this one. And I suspect Professor Isaacson will be quite happy to light the fire as I burn into eternity. I'm going to argue, of course, that we should, where possible, avoid the D2 receptor family. I have to show you the disclosures, which are exactly the same as they were an hour ago, and the point, again, is exactly the same as an hour ago, in that what you're going to hear is what I think and believe, and it's got nothing to do with the organizers or their beliefs at all. And I put up the capsule, as I did before. You may not know, but Dr. Isaacson actually writes the capsule, okay? But I happen to know that when he was writing the capsule, he got distracted and he left off the last 4 words, so I've added them for him. So D2 agonists be avoided when and where possible is, I'm absolutely certain, what he meant to say. And I'm not going to argue against D2 agonists in the respect of the fact they've made a significant contribution to the treatment of Parkinson's disease. We've had an era of D2 agonism. We've learnt a lot from it. We've learnt a lot that's positive, and we've learnt a lot that's negative. And that's the thing about it. You've got to balance the efficacy of the drugs against the lower efficacy they have compared to levodopa, and you've got to balance it against the side effect profile, the adverse events which are produced by the D2 dominant agonists. And the point I really want to make is what we should be doing is exploiting the multiplicity of dopamine receptors present in the brain that offers an alternative way forward rather than one that we've been using for the last 2 or 3 decades. And what I simply want to do to start with is just remind you there are D1, D2, D3, D4, and D5 receptors present in the brain. They have a differential distribution within the brains from an anatomical perspective, and they also have a functional segregation within the brain, which is highlighted in this quite complex slide. And I'll just draw out 1 or 2 examples. If you look at what D1 receptors do and D2 receptors, the pure D1, D2 receptors do, they're concerned with motor activity. If you pull out the D3 dopamine receptor, then we've got a receptor that we don't like because we think it's involved in impulse control disorders, it's involved in mood change, it's involved in addiction. So we know a lot about dopamine receptors, the multiplicity of their functionality. And what you have to remember is dopamine loss in Parkinson's disease affects all these brain areas. It's not just nigrostriatal. You lose mesocortical, mesolimbic dopaminergic innervation. So what we're looking at is something which is complex and affects this whole multiplicity of dopamine receptor pharmacology and dopamine receptor-associated functional segregation. So that's fine. We accept all that. But there was a very strange decision made some decades ago. And I lived through this, and I was racking my brain trying to remember how we got to the point where we finished up. And the point that seems to have happened is that we said 30 years ago, 40 years ago, well, L-Dopa is a fantastic drug, but look at all that dreadful dyskinesia it induces. And at that time, we had ergot, alkaloid-type dopamine agonists like bromocriptine. And the evidence said, well, they produce anti-Parkinsonian activity we want, but they don't actually produce as much dyskinesia as levodopa. And then we did a little bit of simple subtraction, and we went, L-Dopa acts on all dopamine receptors through dopamine, so on D1 and D2 receptors. Bromocriptine predominantly acts on D2 receptors. Therefore, D2 is the good receptor, and thank you very much, but we don't want anything to do with the D1 receptors or the other dopamine receptors. And this was taken up by the pharmaceutical industry, who then used processes known as combinatorial chemistry and high-throughput screening and produced masses of dopamine agonist compounds which were focused on having D2 selectivity, and we then entered an era of using D2 agonists as a predominant therapy for the symptomatic treatment of Parkinson's disease. And this may or may not have been the right decision. In my view, it was the wrong decision. But what it does explain is that when you put up slides like this, which are the receptor profile of the approved dopamine agonist drugs, and you look at where they act in terms of dopamine receptors, you can just simply see that what they are dominantly and predominantly drugs that act on the D2-like receptors, the D2, the D3, and the D4. And the D2 we might like, the D3 we may not like. And what you see on there very clearly as well is that most of them have relatively little, if any, activity on the other major dopamine receptor population, the D1-like receptors, that's the D1 and the D5. And as a consequence of our actions, as a consequence of this, we have lived through an era where we have dopamine agonist compounds which have been very useful as monotherapy and adjunct therapy, but what we've had to do is we've had to live with the adverse event profile of these drugs, which you know very well, and you could probably predict what they're going to be in every patient that you might start on a dopamine agonist drug. And we go through things which are marked problems such as excessive daytime sleepiness, impulse control disorders, hallucinations, and you will know these far better than me because you'll probably see these on a daily basis. And this is the promise and the reality of the oral D2 agonist compounds. We were promised a focused pharmacological profile, and sure, we got that, but we got drugs which are selective for the D2-like family of receptors, and we got D3 selectivity, which is not something that we wanted because it's brought more problems to the door. We were promised efficacy against motor symptoms as monotherapy and adjunct therapy, and sure, you get efficacy, but that efficacy is not to the same extent as you get with levodopa. We were promised less dyskinesia by focusing on D2 receptors, and sure, that's true in early disease, but it's at the price of lower efficacy, and if you go to the preclinical world, it's quite clear that D2 agonists can prime and express dyskinesia in the same way as levodopa. We were promised that we would get rid of adverse events, and we certainly got rid of the ones associated with the ergot-type drugs because they also had effects on serotonergic and noradrenergic systems, but what we were left with was a profile of adverse events based around having D2-like selective potent dopamine agonist drugs. We were also promised a long duration of effect. We were promised we were going to get continuous dopaminergic stimulation. But in fact, the commonly used oral agonists are not that long acting in their immediate release form, and if you have a dose of drug 3 times a day, it's clearly not giving you continuous dopaminergic stimulation, and certainly you're not getting that during the nighttime period. So the reality of the D2 agonists was very different. from what you were promised. And look at the AAN guidelines. Based on the guidelines, it's quite clear what they're saying is be careful when you use the D2 agonist drugs. Think about what you're going to get as a result of using a D2-based predominant agonist. And I think that is the reality, and that was encapsulated by our moderator, by our chairman, when he introduced this debate. And the other strange thing, and Parkinson's disease is full of strange things, is that why have we ignored the other half of the dopamine receptor population? Why have we ignored the D1-like receptors, the D1 and the D5 receptors? We've had these compounds in our hands. We've used them in experimental models of Parkinson's disease. We've even had them in limited clinical trial. They have efficacy against motor deficits in Parkinson's disease. Unfortunately, the previous generation didn't have the oral bioavailability that people wanted. They were very long-acting and started to cause tolerance on repeated administration. And there were some other pharmacodynamic and pharmacokinetic problems with them. And faced with this, what happened was we decided that we'd abandon the rest of the dopamine receptor population, even though we know it has an important role to play in the treatment of the disease. But this is what the potential is for looking at D1 and D5 receptors. We know that they can provide a robust improvement in motor function. We know that D1, D5 agonism has the potential to produce less dyskinesia than you see with D2 type compounds. We know that D1, D5 agonism, from work that's been carried out extensively at the preclinical level, has the potential to improve cognition and other neuropsychiatric symptoms of PD through the mesolimbic and mesocortical systems. And we even know that D1, D5 is likely to cause less nausea and vomiting because that's peripherally mediated through D2 receptors. So we know that there's all these advantages. And as you've heard already from our moderator and chairman, that thank goodness we are going back to looking at the D1 system. Tavapadon, as I call it, is a novel approach to the treatment of Parkinson's disease that's in late-stage clinical trial. This is a compound, if you can read the left-hand side of the slide, which has high degree of selectivity for D1 and D5 receptors, relatively little effect on D2, D3, or D4 dopamine receptors, certainly no selectivity for the D3 receptor population. It improves motor function in the MPTP-treated primate model of Parkinson's disease, which is the most predictive model. It has effects in phase 3 clinical trials, increasing on time and decreasing off time with a favorable adverse event profile. So this is fine. We can go down the road of moving away from the D2 compounds. But the difficulty is this compound's not yet approved. You can't use this compound. But there's something else you should remember, something else that gets forgotten. If you want to get a maximal improvement in motor function in Parkinson's disease, you need to have a drug which will affect both D1 and D2 systems. You need to have a D1, D2 agonist for that maximal motor response. And that's why in some ways we're lucky, because we've already got one. If you look at apomorphine and you look at the receptor profile of apomorphine, and if you look down in that red box at the other end, you will see that apomorphine interacts with the D1 receptor population. So you have a D1, D2 dopamine agonist already, which you can use. The difficulty with apomorphine being, of course, it has no oral bioavailability, and you have to give it by subcutaneous injection or subcutaneous infusion. So are we in a situation of despair? No, no, please don't despair, because you already have the best D1, D2 agonist drug that's probably ever going to be available. You have levodopa. Dopamine from levodopa interacts with all dopamine receptors. It doesn't show any preferential effect of D3 over D2. You have an ideal drug. And this would explain why we lived through the levodopa era. We then were pushed into using D2 agonist drugs, and while why you and your father are already adopting the philosophy I'm suggesting. You're coming away from D2 predominant drugs because what you found from clinical practice is that by having a drug which stimulates all dopamine receptors, all dopamine receptor population, what you're getting is the best clinical results that you can get from a dopaminergic compound. So the conclusion of this is, should we move away? Yes, when and where possible. Selective D2-like agonists are not the only way forward. We've ignored the alternatives within the dopaminergic family. Utilizing the known pharmacology and clinical efficacy of D1, D5 compounds, it just simply makes sense. And the easiest way to do that at the current time is to use levodopa itself, or apomorphine, or you can wait for tavapadon to come along and be approved for use in Parkinson's disease. And with that, I'd like to welcome you to Krakow next year. I'm certainly coming, and the reason I'll be coming to Krakow is my wife's never been to Krakow, and she'll push me to come to this meeting. And with that, thank you very much indeed.
Thank you so much, Dr. Jenner. And now to come and save all of movement disorders from the 90s, 2000s is Dr. Isaacson.
Well, I think we have a lot more in common on our slides than we have apart, although you're wrong, and the answer is no. So as you point out, dopamine agonists are an established therapy in Parkinson's disease. They've been introduced since shortly after levodopa, when dyskinesia and off fluctuations emerged, where they have established efficacy as monotherapy in early Parkinson's disease. They have efficacy as adjunctive treatment for off fluctuations. And the idea that D2 predominant dopamine agonists should be avoided is just not the case. These are very useful drugs for people who live with Parkinson's disease every day. If you don't have Parkinson's disease, these drugs may not be so useful. But if you do, these are important drugs. There's no reason to vilify a class of medications that have decades of experience, because for many people with Parkinson's disease, they're well tolerated and they don't have side effects. For some people, they need extra D2 agonism above and beyond what's achievable with levodopa becoming dopamine in the brain. And we'll talk more about that. And we can't get rid of a class of medicine when we have such limited treatment options already. And finally, until we have alternative pharmacotherapies, we can't get rid of a class of medications that have established efficacy and demonstrated tolerability in most people. We're trying to balance this dysregulated direct and indirect outflow pathways in trying to maintain normal mobility, and that's really the goal of therapy, is to more physiologically activate dopamine receptors, the D1 family, the D2 family, as we just heard. These dopamine agonists that have been developed have long been used in Parkinson's disease. We have a lot of experience in how to use them, how to dose them, which patients to use them and prescribe them for, what side effects to look out for, and what efficacy to expect. We have D2 agonists that are predominant D2. We've had in the past pergolide that had some D1. Rotigotine might have a little. We await tavapadon, that's D1 selective. But there's a lot of history of dopamine agonists. But they've had a rocky road. Tolerability and safety issues have emerged. Adverse events that are dopaminergic have lengthened titration and reduced their usefulness, especially in the states where we don't have domperidone. Off-target side effects have limited their use as well. Ergot agonists have been removed from the market in most places due to fibrotic complications. But these dopamine agonists have many different receptor affinities. When we think about pramipexole and ropinirole and causing hallucinations, it may not be from over D2 or D3 stimulation, because they also have activation, they're agonists at the serotonin 2A receptor, at least pramipexole is. Orthostatic hypotension could be from peripheral dopamine, can also be from adrenergic things. So we really have to think not only about the off-target side effects that occur, but also the efficacy that are derived from the D1 and D2 family. The D2 family in particular and drugs like pramipexole and ropinirole are predominant, may help certain symptoms that levodopa doesn't help on its own. Some of these may be on-target symptoms in trying to stimulate D2 more than levodopa alone. Some of them may be non-dopamine receptor affinities that improve non-motor symptoms. Their efficacy in motor treatments have been established for decades. But it's really the non-motor symptoms where D2 predominant dopamine agonists, I think, have their greatest utility. We have so many patients that have great motor improvement with carbidopa-levodopa. It's been called a miracle drug. But we wouldn't be here if it was such a miracle drug trying to develop new therapies. And many patients remain apathetic, depressed. They may have other symptoms like off dystonia that's painful, sleep issues, pain problems. And by adding a dopamine agonist that's D2 predominant that are available now, we're often able to help our patients in ways that increasing and increasing and increasing levodopa can't. D1 selective dopamine agonists that are on the horizon, like tavapadon, UCB has a partial D1 agonist that's selective as well, may help certain symptoms like cognition, may reduce the risk of developing dyskinesia. And we wait for those. But as Professor Jenner points out, we don't have them now. The side effects that worry us about D2 predominant dopamine agonists affect some. In one of the largest studies, about 17% of patients taking a dopamine agonist that was D2 predominant with levodopa developed compulsive disorders, 14% on a dopamine agonist alone, but 7% on levodopa alone. It's part of Parkinson's disease in treating patients with dopaminergic therapies, and we can't vilify a single medications. Psychosis had been linked with dopamine agonists with hallucinations, but this may just reflect a dosing, idiosyncratic, a serotonin 2A agonism, or other factors, and most people don't develop hallucinations. Sleep attacks were talked about to try to vilify D2 predominant, but many of these patients have sleep apnea or other sleep disorders that make them sleepy. And we can't vilify a single drug when it's also part of the underlying non-motor apparent of Parkinson's disease. Orthostatic hypotension is present on a neurogenic basis in most patients with Parkinson's disease due to an inability to release enough norepinephrine on standing. To vilify a drug that has benefit for patients when it's part of the underlying degenerative process in Parkinson's disease is problematic, I think. Dopamine agonist is an imprecise term, and we probably should do away with it, as we have D2 predominant dopamine agonists that will probably go away once we have better options. We have a dopamine-like dopamine agonist like apomorphine. Levodopa becomes dopamine in a similar fashion, but apomorphine, despite its robust benefit, can't be given orally and is limited in that way. The D1 family selective agonists are not here yet. This is a version of the same slide that Professor Jenner developed in his lab and is published on this. But here we can see that until we have an oral dopamine-like dopamine agonist, until we have D1 selective that's devoid of D2, we have what we have. And we have to make the use of what we have. And we can't throw in the wastebasket medications that help a lot of our patients just because some have had problems with it. We await new selective D1 family agonists, but they're not here yet. So I think overall, dopamine agonist therapy in Parkinson's disease, should they avoid predominant D2 family receptor affinities? No, because they help certain people. The risks of currently available medications are not much higher than what we use anyway, including levodopa. Other treatments we don't have to treat non-motor symptoms as effectively as a dopamine agonist. Dopamine-like receptor agonists have long been used with robust benefit and demonstrated tolerability. We await selective D1 dopamine agonists, but until we have them, we can't abandon drugs that are tried and true and that have helped a lot of our patients when increasing levodopa has not. So I'll stop there, and I'll step to the side as Professor Jenner rebuts me, and we have to remember that everyone's entitled to their opinion.
Professor Jenner, you may take the stage if you like.
Yours may not be correct, to quote Warren.
Dear, dear, oh dear.
as you said at the beginning, there's more in common in what we've both said than there is disagreement. I don't think we should be junking vilifying was the word you used, the D2 agonist compounds. I think they've got a use. I think I'm just for moving away from that class of compounds because we've had several decades of experience of what they can do and what they can't do. And unless we expand the horizons, unless we start looking at the rest of the dopaminergic system, we might as well say, well, let's finish with dopamine, let's go and look for some other class of drugs. And I'd still come back to the point that the 65-year-old drug that everybody here uses and every patient with Parkinson's disease needs remains the best drug for treating the disease. And we have to ask ourselves, why? And the answer is because it replaces dopamine at all types of dopamine receptors. It's much more physiological, and it's the biggest clue we have to what we should be doing rather than going for selectivity. I'm not sure a pure D1 compound is the best way to go. I'm not sure a pure D2 compound is the best way to go. I think some of the compounds which have a spectrum of activity across the dopaminergic system might give us something as good as levodopa. But I'm not absolutely convinced in my own mind we're ever going to surpass the superiority of levodopa. We've had 60 years of academic and industrial research looking for something better, and we haven't got it.
All I can say is that your hero, levodopa, deserves a sidekick, and that's a D2 predominant dopamine agonist. Used together, they work better than either one alone.
We have time. Should we take some questions? And then we will proceed to the post-debate voting. But any questions?
Hey, great presentations. So here's a question, though. Is the use of a D2 family agonist confounded by the fact that they have longer clearance half-lives, are more consistent in stimulating receptors, something that Peter Jenner's favorite precursor, levodopa, doesn't have? And is that part of the story? And in fact, as we judge the improvements that dopaminergic agonists over really 40 years plus have offered, is partly that mixed in. Now, I'll say as a clinician, clearly the labels and the indications for D2 agonists are not really representative of how I, as a clinician, use them. The treatment of early morning dystonia and so on are just examples that the typical pitch to clinicians doesn't really get the whole story there. But it's interesting, everybody who's treated with a dopaminergic agonist generally is getting levodopa to get maximal effect. So they are getting a D1 stimulation. Do you need to go an extra mile, adding an increment of benefit with a D1 selective agonist, or to think that you need more than D2? That's a pharmacological question that really hasn't been well investigated. And let's add to the story in rodent models that if you use a D1 selective antagonist, such as sharing SCH23390, you don't really make the Parkinsonian relief of levodopa worse. So you could actually argue that you don't really need too much of that D1 stimulation to increase mobility.
I've been around in this game almost as long as levodopa, so this is my 51st year in Parkinson's disease research, okay? So I've lived through these cycles of levodopa, no, bad drug, dopamine agonist, good drug, dopamine agonist, bad drug, back to levodopa. But one of the things, Peter, I can tell you is I've probably tested more D1 agonist compounds in MPTP-treated primates than anybody who's still alive, okay? When you give them a D2 agonist compound, they develop this driven, stereotyped, forced movement. When you give them a D1 agonist compound, they have beautiful, controlled, normalistic movement. There is a lot to be gained from exploiting the D1 receptor, and I still think we've ignored it for far too long, and we've gone down one road at the expense of having a panel of adverse events which may be relatively low but are still there.
Well, I think that heralds the D1 debate in Krakow.
Fair indeed.
All right, well, let's take it to a vote, everybody. Neck and neck.
Well, I think that means we like dopamine agonists, right? But we have to
Very
just
good.
find which receptor we want. All right, great. I think we've come to the... All right, so now we're going to move on to the next session. And we have some new chairs coming up for this. No, it's apparently not. It looks... There's coffee out there, but there's no break.